So the first specimen is a 57-year-old female who presented with left ovarian mass, and she received debulking surgery at a hospital, and this is the peritoneum washing during the operation. So on low power, because it's a washing cytology specimen, it's easy that we can see some larger fragments. If these are benign mesothelial cells, usually it's more flat. The specimen also mixed with some inflammatory cells. However, we start to identify some like a smaller cluster, and if you compare the nuclear chromatia just on low power, you can appreciate that these cluster looks darker than the adjacent cluster. So again, now we have a more three-dimensional glandular cluster comparing to the more flattened mesothelial cells. So this is adenocarcinoma. So this is compatible with metastatic adenocarcinoma, already involved the peritoneum. So usually these type of specimen, we will see plenty of these malignant cells. And the most common scenario would be the high-grade serous carcinoma, particularly in these postmenopausal female. So the clinician sometimes will also do direct smear from the diaphragm. They would do the right side on the liver cervix as well as the left side above the above the stomach. So by direct smearing, you can also see this is also a flattened sheets of relatively bland-looking cells, and if you pay attention to the chromatin pattern, it's very delicate. It doesn't show hyperchromatia. So this is benign. This is just a mesothelial cell from direct smearing. But these cluster of cells, you can definitely appreciate the atypia. So this is very big with a very big nucleolus, and just within the cluster, we see variation of the size of the nucleus. A smaller nucleus over here, a much bigger over here. So if you compare with these benign mesothelial cells, this is malignant. So there are very scant malignant cells here in these direct smear of the diaphragm. So this is positive. So the next case is the patient of lung adenocarcinoma. This is the pleura effusion specimen. So in the background, we do see a lot of inflammatory cells. On this power, it's a little bit difficult to identify like a so-called two-cell population because the inflammatory cell is very dense. However, we move to the medium power, and then you start to appreciate there is a cluster of cells with more three-dimensional architecture. And when we go to higher power, it does has a glandular arrangement, and you can appreciate the nuclear polymorphism. The cytoplasm is more loose with a little bit vacuole somewhere over here. And you can appreciate the variation of the size and shape of the nucleus. Although we didn't see very prominent nucleolus, but because of the three-dimensional architecture, the polymorphism, this is an adenocarcinoma. So there were only a few clusters of these type of cells. So sometimes it's quite easy. If you go on low power, you already see them. But sometimes if the background show a lot of inflammatory cells, these cluster can hide in the background of the inflammatory issue states. So we check the cell block preparation. Again, the tumor cell is pretty scant, but you can appreciate the classic traction artifact from a cluster of glandular cells. So this is positive for adenocarcinoma. So the next specimen is also a patient of lung cancer who has been proven before. So in this specimen, I think the tumor cell is even more scant. The background, we didn't see a lot of cell, only a little bit of inflammatory cells. We don't even see a lot of mesothelial cells. And then we see a few cell cluster. So this cell is definitely not reactive, right? Because you compare with these PMM, the neutrophil over here, this is way too big. The nucleus is way too big. It has an eccentric pattern. The cytoplasm show vacuolation, and you see prominent nucleolus over here. So this is a poorly differentiated adenocarcinoma. There were only these more apparent cluster. I would say this cluster is a little bit difficult to interpret because most of the cell has these histiocytoid pattern, so it looks like a histiocytes. However, there was still some vacuolation, and the cluster itself is kind of in three-dimensional. Again, you see the focus is over here, and these all loss of focus. And then I focus over here, these disappear. And then I see a pseudo inclusion. Pseudo inclusion can be present in lung adenocarcinoma. So this cluster is also likely an adenocarcinoma, but because of the morphology, it's a little bit ambiguous. So if this is the only cluster that we see, I probably call these suspicious. But because we see these unequivocal cells and the patient already had a confirmed history in the previous pleura effusion cytology, so we call these adenocarcinoma. So sometimes the recurrence or persistent disease, you will see the tumor cell will be really, really scant, and you need to pay attention for the screening. But sometimes you will see a lot of them. So next specimen again, it is a patient from emergency department, but she also had a past history of lung cancer. This is also a very similar situation. In the background, we do see more flattened and loosely cohesive cells. So these like histiocytes or mesothelial cells. And right next to it, you find these cluster of three-dimensional tumor cells that show the nuclear size is apparently bigger than the adjacent normal cells, like 2 to 3 times bigger. The chromatin pattern, you can appreciate that this is the vesicular chromatin pattern. Somewhere you didn't see any chromatin, like a granule. The other area you can see more clump chromatin. And this is very different from the normal cell, usually have a very equally distributed, delicate, finely granular chromatin. And then within this cluster, you can identify there are a lot of cells show distinct nucleolus. So this is an adenocarcinoma. And this is actually not very easy to screen. Yeah, it is just hiding in the background. So again, we have another cluster, and this cluster is like a three-dimensional. It looks like it is an adenocarcinoma. So for this case, the tumor cell is scant, and then in the cell block, it's also very scant. But I think the morphology is pretty good for adenocarcinoma. The next specimen is a CSF specimen. The patient also had a history of lung adenocarcinoma. So you can see this is very common. This is the most prevalent cancer nowadays in Taiwan. And in these CSF specimen, we only find very scant, a few cells, possibly less than 10. But because of this morphology, and if you compare with the arrow, the nucleus is big, the NC ratio is high, and it also shows these typical, like a snotting or like a skirt around the cell, this kind of pattern. This is very common in metastatic adenocarcinoma, that it will show this type of pattern. And here you see more apparent nuclear like irregularity. So this is metastatic adenocarcinoma. So the morphology in the CSF, the adenocarcinoma is usually very different from the pleural effusion, from the other body fluid. It is less likely to be in a cluster with three-dimensional cluster. It's more common to be in individual cells. Sometimes the cell looks a little bit bland looking because it's a single cell and you don't have the reference in the background. But because of this high NC ratio, and if you compare with the arrow, the nucleus is actually big. The cytoplasm, like a border, will show this knot or skirt-like pattern, and this is a typical adenocarcinoma metastasized to the CSF specimen. Again, lung cancer. So we have so many lung cancer. Yeah, so the specimen from pleural effusion, it's not very cellular, but we do have very tight cluster and with very high-grade cells. So this is easy for diagnosis because this is definitely malignant. Okay, so for this one, it's easy. It's not very cellular, but it's obvious. It's diagnostic. And this is the cell block. And we also see like similar cells in the cell blocks. The next specimen, I personally think is a little bit difficult to interpret. This is a 50-year-old female. This is an ascites specimen. The patient has a past history of lung adenocarcinoma with multiple anatomical site metastases. So this is below the diaphragm in the ascites. So we have a cytospin preparation. As you can see by these artifacts, there is no cell actually in the center, but all has been like pulling around the periphery. And low power, we already see some cluster of very dark staining cells. So we go to higher power. I think the cell morphology is actually intermediate between a small cell versus a non-small cell. So I think at the beginning of this week, we do see, or last week, we do see a case. Naturally, it is a mixed small cell and non-small cell adenocarcinoma. And initially, we only see the small cell component in the pleural effusion. And then we have sent out 3 times for small cell carcinoma. So the patient has been treated with small cell carcinoma chemoadjuvant. And then the small cell carcinoma has response, and the adenocarcinoma component come out. So in the 4th specimen of the pleural effusion, we see an unequivocal non-small cell adenocarcinoma cluster. So that situation is coming from a tumor with initially just with mixed morphology. However, in a non-small cell adenocarcinoma, if the patient has been treated for a long time, it will develop resistance, particularly for the targeted kinase inhibitor. And there were a lot of different ways to develop these drug resistance. One of the way, it's not so common, but we occasionally will see, is so-called trans-differentiation. So the adenocarcinoma can trans-differentiate it into a small cell carcinoma. So this is the situation is different. Okay, I think for this case It's actually in the intermediate stage. Yeah, because you can definitely see classical feature like molding, high NC ratio, and the chromatin pattern is very kind of like salt and pepper pattern. However, some of the clusters still maintain more cytoplasm and with a rosé or glandular type of feature. So it is kind of very difficult to make diagnosis. So we do have cell block. So for the cell block, I think some of the cell does has a glandular feature, but the other may looks a little bit like small cell carcinoma. So we will do some scan on these case. We will do TTF1 to confirm, first of all, it is coming from the lung. So TTF1 would be positive for both adeno and small cell carcinoma. And then we will try to do some neuroendocrine marker. So here we find more cytoplasm. The NC ratio is relatively lower for the cluster. It seems to have a glandular feature, but the chromatin pattern actually looks like neuroendocrine. So it's kind of in the middle. So the cancer cells are smarter than we think. But if it has developed a small cell carcinoma, we need to tell the clinician because they need to change the regimen from targeted therapy to the chemotherapy. So that information is kind of important. The next specimen is from a 70-year-old male. We have seen two specimens from the same patient before. Both of the specimen we sent out malignant lymphoma, and then the patient received the peritoneum, retroperitoneal like biopsy, and confirmed to have diffuse large B-cell lymphoma. So the patient is now under treatment for lymphoma, and this is the third pleural effusion specimen that we received. And it started to have these very three-dimensional cells with cytoplasmic vacuole. The cells show distinct nucleolus, sort of like glandular arrangement. So nowadays, I have to tell you, 10 years before when I started my practice, every patient will have only one cancer. And nowadays, it's very common that you see the patient have 2 different cancer, even 3 different cancer, and the cancer can even shift with the differentiation. So that is kind of more challenging than it used to be. Because of the new treatments, the treatment will be effective, so the patient lives longer and have time to develop a second cancer. So it looks like the patient treated for lymphoma then to sort of have metastatic adenocarcinoma. So we definitely need to have immunohistochemistry to confirm if these are true adenocarcinoma or if these are just the reactive changes from the mesothelial cells to develop like a feature, cytomorphologic feature, mimicking adenocarcinoma. So that is, so I would say that our practice is getting more and more challenging every day. But this definitely looks like adenocarcinoma. So it is likely the patient have lung adenocarcinoma plus diffuse large B-cell lymphoma, and all occur in this admission, and we treat one, and the second population become more obvious. Yeah. So let's move to the fine needle aspiration. This is from the pancreas. On low power, we see a lot of cells. We see some like old blood admixed with mucin in the background. And we see very large fragments. So this is what we call disorganization or drunken honeycombing. You can appreciate most of the cells is not rounded. It has some elongation and irregularity, and you can appreciate that the distance between each of the cell is very disorganized. And if you put the long axis around the cells, it's all crossing with each other. So this is well differentiated to moderate differentiated adenocarcinoma. And in this specimen, we do have a lot of these type of cells. Because this is a liquid-based specimen, so sometimes quite in three-dimensional. You need to focus up and down. And here is also a more flattened fragment. And here you do see a signaling cell morphology with oranginophilic mucin in the cytoplasm. So we see abrupt mucin formation. So this is an adenocarcinoma. So this is again a different patient with aspiration of the pancreas. In the background, we see necrosis. And here we do see very bizarre, very ugly tumor cells. So some cell doesn't have any differentiation, it just purely poorly differentiated. But the other does show some area demonstrate that it's a glandular differentiation, such as this one. So we see a very tight cluster and with polymorphic tumor cells and three-dimensional. So this is a glandular component. So the tumor does has well-differentiated and poorly differentiated component admixed with some normal mucosal contamination. So this is the normal mucosa. You can see all the cells are rounded. It has a nice, like an equal distance between each of the cells. So this is very well organized comparing to the drunken honeycombing that we just see. So this is also positive for malignant and adenocarcinoma because you can for sure see well differentiated glandular cells over here. The next specimen is parotid gland aspiration. The specimen is a little bit unusual comparing to the other specimen that we used to see. So on low power, we do have a larger cellular fragments composed of very dark cells. So when you go to higher power, the cell does has a higher NC ratio, so it got the basaloid looking. However, some cell does develop an oval shape, and some shows like a disassociation in the background. So they does has a myoepithelial like a feature. So we see a lot of basaloid cells with myoepithelial cell feature. So our differential diagnosis would be, could it be just a very cellular PA? Or could it be a basal cell tumor? So the diagnostic approach would be a little bit different. If it's a PA, we might probably just call it benign PA. But if it's a basaloid tumor, we might probably call this some with basaloid feature. And here, in addition to the basaloid cluster, we do see some cluster arranged in these like ductal type of arrangement, glandular arrangement. So we start to see a different component other than these basaloid myoepithelial cells. In the background, it's very, very difficult to find a typical chondromyxoid matrix. So for the aspiration specimen, if you want to see the matrix, we usually would rely on the Lewis-Tan, the dry smear with Lewis-Tan. So if you go to the Lewis-Tan, you can start to appreciate that indeed we do have a very high NC ratio basaloid cell looking like cells, but you also see these delicate fibrillary extracellular matrix has very close relationship with the myoepithelial cells. So I think this is a cellular PA, and we have very good visualization of the extracellular matrix on the loose stem. So I turn to make the benign diagnosis, suggest that this is a PA, instead to call this a SUMP, SUMP polycyloid tumor, because we do see typical matrix material with fibrillary feature. So these actually reduce our diagnostic rate for indeterminate diagnosis for SUMP. Because SUMP is an indeterminate diagnosis, it's better that we use as less as possible. So I would call this a benign PA. But before signing out the case, I also order a cell block. So let's take a look at the cell block. So in the cell block that we do see a similar feature, but more obvious that the matrix material can see this fibrillary feature all admixed with the myoepithelial cells. And some area it looks like it start to form a little bit ductal differentiation, very similar to what we see on the cytology specimen. Additionally, there is something interesting. Again, I just want to show you this is typical for a PA. And you also see some ductile right here. So you see two different components. And interestingly, there is one cluster. It shows very classic squamous cell metaplasia, and with these keratinized hole formation in the center. We do not see these type of cells on the smear, but in the cell block we do see the metaplastic change. So sometimes PA can have prominent squamous metaplasia, so these need to be taken into account. When you see a well-keratinized squamous cells, you need to think about metaplasia. And if you think about mucoepidermoid carcinoma, in mucoepidermoid carcinoma, you will almost never see well-keratinized squamous cells. Most of the cells are intermediate cells. It's very, very rare you see well-keratinized cell. So whenever you see a well-keratinized cell, you need to think about metaplasia instead of think about mucoep right away, okay? So the next specimen is a bone aspiration. This has been weighted for the final diagnosis from the biopsy. Let's take a look. So for this specimen, the cellularity is not very high, but we do see very high grade individual cells with very high NC ratio. And if you pay attention to the chromatin pattern, it is irregularly like a coarse and clumps, and some cell you can find nucleus. And most of the time you will find like a tiny nucleus attaching to the membrane of the cell nucleus. So these actually looks like high-grade plastic lymphoid cells instead of just poorly differentiated carcinoma, because for the poorly differentiated carcinoma, usually you will see one single or one or two, like a very apparent giant nucleus in the center, instead of these type of nuclear chromatin pattern. So in the biopsy, they sign out this is compatible with a diffuse large B-cell lymphoma with bone marrow involvement. So this is a high-grade lymphoma. It's a little bit unusual because the cell is actually very, very big. If you compare with the reactive lymphocytes, it's like a 10 times bigger. So it's much bigger than the usual lymphoma that we see. But by immunohistochemistry, it has been confirmed with a B-cell differentiation. So this is a high-grade lymphoma with bone marrow involvement. It's already 9:30. I think we can skip the PTC and these. I just want to show a hard smear specimen. So this is coming from a 72-year-old female with postmenopausal and vagina bleeding. So this is her pap smear. On low power, you can already appreciate that there was some old blood, and in the background it seems to be quite dirty. On this power, it's a little bit difficult to determine because sometimes atrophic vaginitis will also have these like a very dirty granular background, but most of the cells were composed of neutrophils. However, in this specimen, you do see some old blood and more than usual like a dirty granular background. So you go to higher power. You do not see a lot of neutrophil. Instead, you see a lot of these hyperchromatic nucleus, and most of them will have these oval to spindle shape. Some of them actually preserve the cytoplasm, so you can appreciate that it does has a keratinized cytoplasm, right? So this feature is throughout the entire smear. So this is a very classic squamous cell carcinoma, invasive. Okay, so this is an invasive squamous cell carcinoma. So pay attention to these tiny little spindle cells. Sometimes we will see these, and sometimes it's only a parakeratosis. But if you start to feel that the hyperchromasia is more than usual and the NC ratio is high, and then you start to see some accompany like necrotic cell debris, for example, like these spindle shaped cells is actually necrotic cells, right? So if you start to see more of the hyperchromasia and even with some like necrotic cells in the background, you need to think about the possibility of the squamous cell carcinoma. Okay, so this is a very classic squamous cell carcinoma. So you find well-preserved like a basal cell with high NC ratio. You also find superficial cells. And in the background, you see prominent tumor diastasis. So this is a typical case for a squamous cell carcinoma. Okay, so that's for all the cases today. Luis, yes, so today in the afternoon I need to go to the university to teach.